everyone, and welcome to the Ostrom Data Trust Salon series. This week with us is Greg Bloom, who's going to speak about the work that he does as it relates to data in the health and social services fields. Greg?
Right on. Thank you, Angie. I am a visiting scholar with the Ostrom Workshop on the Commons at Indiana University, and I'm really grateful to Angie for sort of taking me under her wing. It's been a privilege to learn about this stuff at the Ostrom Workshop. This is the place where I discovered that there are potentially solutions to some of the problems that I'm going to be talking about, which for a long time felt pretty intractable. And so it's exciting to study alongside people who are experts on governance of shared resources. I think this is the most important work in the world. So it's an honor to be here talking about it. So I came to the Ostrom Workshop as I was trying to figure out a problem that eventually became something we addressed through an organization called Open Referral, or an initiative called the Open Referral Initiative. And I've given a few talks about Open Referral at the Ostrom Workshop. They are available online. And also I've written a paper in partnership with the Open Referral Workshop, with the Ostrom Workshop, about the tragedy of the resource directory anti-commons. So this is information about health, human, and social services, which is currently managed in many redundant, competing, fragmented silos. And we discussed through this work how we might build a commons of information about services that could be shared across systems as a public good. This talk is a sequel to that one about different problems in the same field. And much like any sequel, it is going to be repackaging my intellectual property from the last version into something bigger and messier. So bear with me as I work through this. Actually, Waldo has seen the first version of this talk that I ever gave. I'm not sure that it went very well. Hopefully I'll marginally improve this time. Here we'll be talking about the tragedy of the dueling care platforms among health, human, and social service providers. And I'll have this talk in two different segments. The first, I'll talk about this problem space, and in the second one, I'll look ahead. In the second segment, I'll look ahead towards what interoperability and governance of client information exchange might look like. And at the end, I'll have a big open slate of questions that hopefully you all can join me in thinking through. That the last couple slides I was literally putting together as Angie was letting you all in the room. So our story starts. For the deep background, you might want to check out the talk, but I'll cut out some of the personal history here and some of the details. But basically, the challenge of navigating the safety net has historically been something managed by an industry known as information and referral, INR. And there's a sector of information and referral providers that act as intermediaries that aggregate information about the health, human, and social services available to people in need. And they provide that information in hopes that people can figure out where to go to get help. This is an old industry. The practice of information and referral goes back to libraries in the early 20th century. And in the 70s, the Alliance of Information and Referral Systems, AIRS, formalized this whole sector. And in the 90s, a system called 211 emerged as the sort of official information and referral hotline sanctioned by the FCC. But 211 is managed by a decentralized network of nonprofit organizations, state by state and county by county. There are different 211 organizations. And there are also topic-specific information and referral providers like veterans hotlines, aging and disability resource centers, child care resource and referral centers. They are historically the stewards of information about the safety net. And increasingly, there are an emerging class of web-based startups that are disrupting this field in ways that might sound very familiar to other fields like transportation and media and so on. When I first started this work back in 2013, there was already a startup known as Aunt Bertha and a range of other startups that are already come and gone. Now there's Unite Us and Signify Health and NowPow and Healthify and Activate Care, and there's a lot of others. This is not an exhaustive list. Activate Care was actually the only one of them that actually reached out to me and said, hey, we want to talk about this problem. So I gave them a little twirl here. But this is an emerging field of startups that are essentially competing to be the web interface for people searching for services and providers coordinating that care. This market has heated up. When I first started doing this work, there were a handful of startups, and now there's more. Almost every month I learn about a new initiative. And the reason, other than just like the general need for people to find services, the reason this market is heating up right now is associated with a very unlovely jargony phrase, the social determinants of health, which is just a very complicated way of saying that when you're poor, you get sick. Right? And the social determinants of health is a very hot topic in healthcare right now, because it's a very difficult problem, because what it essentially implies is that it doesn't matter how great your healthcare is in the clinic. If you are poor, if you have bad housing, if you have to work 3 jobs and you still can't pay your bills, you're going to be sick, no matter how good the medicine and the care in the clinic is. And this is now a really big deal and a really big problem, because after the passage of the ACA, the Affordable Care Act, Obamacare, there's a great shifting of incentives in the healthcare sector, in which previously, when people would get sick and go back to the hospital because they kept getting sick, the hospital would continue to get paid. And after the Obamacare, incentives for health insurance companies and health providers shifted, because Medicaid now caps the amount of funding that people that is associated with Medicaid patients, and payment is now based on value. And accountable care and managed care, which basically means that you only get so much money to provide to care for people. And if they keep coming back, you have to keep providing care for them, but you don't necessarily keep getting paid if you're a healthcare provider. And so healthcare providers now desperately want to make sure that people's needs outside of the clinic are getting met. And they are seeking solutions. And those solutions are most commonly proposed as new technology that can connect people to health, human, and social services. Now, some of you may be thinking that the best way to address people's social determinants of health would be to ensure that they have a guaranteed basic income, a guarantee of housing, and access to the basic resources that one needs to live with dignity and respect. Like, that would be a very simple solution to this very complex problem. But understandably, nobody necessarily feels like they can wave a magic wand and make those things happen. And so they look for, what else can we do? And the easiest available answer is, we should build technology that connects people from the healthcare center system to social services. So we have this emergence of this field of social care coordination platforms, and I will quickly describe what it is they more or less all try to do. These platforms hope to screen people for their social needs. So they figure out what is going on with someone that might actually be addressable outside of the health clinic. They try to find them resources, and this is where this intersects with open referral, the challenge of resource directory information. They try to figure out where are the services that might address people's social determinants of health. They make warm referrals, or at least they want to make warm referrals, where a provider can actually send someone's information to another provider, and then they want to close the loop. They want to hear back what happened with that patient when we sent this to them to the food pantry or to legal aid. They want to know what happened as a result of that interaction. They want to be able to track people's progress towards care or understand where their gaps are. And they want to be able to monitor this activity for business intelligence and also artificial intelligence. That's the basic value proposition of what is now a very lively market that is emerging and going community by community to try to capture as many of the organizations into these platforms as possible. The problem here is that these are very complex problems, and one software system cannot possibly solve everyone's problem. And furthermore, most decision makers don't really want to hear that these are complex problems for which there are not simple solutions. They want to hear, I will procure a piece of technology and people use that technology, and then people's social determinants of health will be addressed. And so this market is selling itself to healthcare, insurance companies, large hospital systems, philanthropies, and governments, pitching a product that is going to be used by service providers and people seeking help who might have no choice in that process of which platform to procure and which tool is appropriate. So this is what that sort of looks like. And this is an adapted slide from the Open Referral Initiatives framework. Open Referral was dealing with the right side of this slide, information about services. We were trying to make sure that information about services, rather than being collected in all these competitive silos, was actually being shared across many systems concurrently. And in this instance, we're dealing with information on the left part of the slide, information about people. Whereas right now you have all these different channels competing for access to providers and competing for a share of the market of people in need. And what is essentially emerging is what you might call platform colonialism, in which you have different companies trying to claim as much turf as possible and trying to capture health systems and community organizations within the platform so that they can provide warm referrals and close the loop among organizations using the platform. But of course, what this ends up doing is creating more silos. It recreates, in the attempt to break down the barriers to care, you're essentially erecting new ones. And you also have the problem in which early winners in this are positioned to become monopolies or even or sometimes oligopolies, and then potentially keep other innovative new approaches to coordinating care out. And furthermore, this whole trend threatens to medicalize the social service sectors. Since it's being driven by healthcare, you get very familiar concepts from healthcare emerging in this market, in which social service providers like food pantries or legal aid providers or social workers are suddenly entering into what you might call a narrow network. Much like healthcare, you're only able to see a specialist provider if they're in your healthcare provider's network. Otherwise, you're paying out of pocket. And that's essentially what is happening by default as a result of this market grab in the social service space. And in the long term, we can imagine that this is potentially going to make access to social care contingent upon its ability to deliver savings for health insurance companies' bottom lines. And finally, the big question is, how does all this collection, this surveillance, the collection and extraction of data about people's interactions with their care providers and care providers' interactions with each other, that ultimately accelerates this process of datification, in which people become products for machine learning and algorithmic governance that end up removing human judgment and human relationships from these equations, and putting people at the mercy of faceless, shapeless algorithms. So actually, this is the end of the first part of the talk. And I'm still looking for ways to explain to people who maybe haven't thought as much as the scholars in the Ostrom community have thought about like why this is potentially a threat to human dignity, to the functioning of the marketplace. I'm constantly looking for new opportunities to explain this, but we already see some examples of how well-intentioned attempts to treat the social determinants of health end up going awry, where we've seen case studies in which access to care is contingent upon how beneficial that care is, but the measure of benefit of that care is, if for instance, it's measured by proxy through how much spending the healthcare system allocates towards a patient. And in at least one case, we've seen that because hospital systems don't spend as much money on Black people as they spend on white people. They think that care is more effective for white people and use these algorithmic decision-making tools to systematically deny care from Black people, not on the basis of any rational decision of who deserves what, simply because they're amplifying the existing biases that structure the data that's being piped into these systems. And so the question is, how do we avoid these sort of market failures that might inherently come from a tech-first colonial approach to solving these problems? I'll pause here to see if there are comments or questions before I start jumping into what we might actually try to do to avert this tragedy. I guess no questions, which maybe that means I'm killing it so far. Or maybe we'll just hold it for the end. Okay, cool. I see a chat actually. Let me see if how's it going. All right, preach. Thank you. Thank you, Susan. Here we go. Okay, so can it be another way? What kind of better world might be possible? This is very simple. This is very similar to the vision for open referral, for folks who've seen me talk about it, which instead of trying to reward the one best system that we hope everyone will use, what we want is the healthy information ecosystem in which there might be many different tools that are designed for many different types of users, but they're aligned around some common protocols, common standards, common infrastructure, and they are governed to ensure that they are ethically operated and used. This is a kludgy, simplified version of what I'll be talking about for the rest of the talk. Information exchange infrastructure that enables many different referral systems to interoperate with each other, with protocols that ensure that that interoperation is standardized and predictable, and the question of governance, which is what I'll try to focus the last part of our conversation on. So to recap, protocols to establish interoperability and data portability. Infrastructure to establish open access functionality so that it's not just that an organization can make a referral to another provider within the software system that they're using, but the software system is interacting with infrastructure. So an organization using one software system can make a referral provider to an organization using a different software system because they're all using common infrastructure. And finally, governance. The question of if data is going to be flowing among these different systems, how do we monitor that? And what kinds of mechanisms can we use to govern it and make decisions about it? So the good news is these are all very hard problems, but we are actually making progress in several of them. And I'm excited about this moment in a way that when I first looked at this problem back when I started getting into open referral, I thought it was intractable. I thought the directory problem was going to be hard enough, but dealing with information exchange about people seemed like a nightmare. And this is a comic that came up almost every time I talked with technical people about the prospect of universal standards. It's amazing how frequently technical people who build tools will bring this up to sort of diffuse conversations about how we can all adopt common standards. And what it's basically describing is a collective action problem, right? Which is the subject of Ostrom's study in governing the commons. And in open referrals case, the way we solved the collective action problem was changing the word competing to cooperating. Instead of saying, this is ridiculous, we need one universal standard that will solve everybody's use cases, we said, we can develop a standard that aligns currently competing standards, whether they like it or not. We can develop the capacity to translate among different kinds of systems and facilitate cooperation across the field, right? And so it's been long and slow, but we've managed to do it. There is another way out of this collective action problem, though. And I am excited to say that we're currently seeing this happen in the field of electronic medical record systems. And shock of all shocks, we have the Trump administration to thank for it. The Obama administration, when they put forth Obamacare, basically said to the healthcare information exchange market, they said, please cooperate. It would be great if you all adopted common standards. And nothing happened. And it became sort of a running joke in health IT, right? That like, yeah, thanks, Obama, basically, for asking politely for the healthcare sector to adopt common standards. The Trump administration came in and was just like, there's going to be standards. This is it. Right? They just took a top-down approach and said, everybody who wants to do business with Medicare and Medicaid has to adopt common standards. They wrote it into policy, and now there's alignment across the field. What's going to happen is still a little bit TBD. This is still a long-term undertaking, but there's much more interest in cooperation in these fields now than there was when I started looking at it 6 years ago. The winner that they picked is known as Fast Healthcare Interoperability Resources, FHIR, which is a part of the HL7 Healthcare Data Exchange Framework. For those for whom this means anything and who care, FHIR is a RESTful API framework. It's specifically for health data exchange among systems. Compared with previous health data exchange frameworks, this is just like you're able to use an API to ask for specific information about specific people rather than getting the whole document. And this is now federal policy that providers have to use it. It's policy set by the Center for Medicaid Systems and also the Office of the National Coordinator for Health Information Technology within HHS. So this is the law of the land. The Gravity Project has been formed to address the social determinants of health, because those standards were emerging in health information exchange, but they don't address social services and human services in the associated terms. So the Gravity Project is a new initiative developing terminologies to describe the social determinants of health, right? School, your education, your access to food, housing, et cetera, et cetera. They're developing terminologies that they're also implementing in clinical vocabularies like LOINC and SNOMED and ICD-10. And they're beginning the process of establishing protocols for exchanging information between healthcare and human services, right? So this challenge of protocols is at least in the process of potentially being solved in the industry. There are still unsolved problems, and maybe problems that are not actually solvable. First of all, you have the challenge of, as hard as health information exchange is within the healthcare sector, it's at least structured according to a common regulatory framework of HIPAA. There are serious challenges with HIPAA, but it's at least like everybody has to like abide by this specific set of rules. And when it comes to healthcare and social services, you have a vast set of domains that have different regulatory frameworks or potentially even no regulatory frameworks, which means the question of how to enable interoperability for patients of healthcare and clients of human services is a regulatory challenge. I don't think this is the hard one though. Semantic interoperability, I think, is potentially an unsolvable problem, because you have healthcare providers who use certain kinds of words to describe certain kinds of social circumstances. And those terminologies are not used by, and maybe not even appropriate for, human services and social service providers, right? Different people use different words to describe the same things. This is the oldest commons tragedy in human history, and I don't expect it's suddenly going to be solved, although maybe we can cope with it. And the Gravity Project is trying to figure out how to do that. And then economic incentives. This is, I actually think, the biggest challenge. And I'll speak a little bit more about it later, but healthcare providers have strong incentives to refer their clients to social services. Social service providers don't necessarily have strong incentives to receive more clients from healthcare. And I think people in these spaces don't realize that the way we allocate resources for people's social needs is essentially ad hoc, and it's not rational, it's sentimental. Organizations get grants and charitable donations or contracts, but that funding doesn't necessarily have anything to do with how many people they serve, right? A social worker does not necessarily work for an organization that gets more funding if another person walks through the door, right? And so it's not clear what incentives human service providers and social service providers would even have to adopt these common standards and start interacting with and sharing their patients' information with healthcare providers. They have a lot of risks, a lot of costs, and not many clear benefits. But I'll come back to that. The next part of the puzzle of how do we pursue an equitable solution to this problem is infrastructure. In this case, it's infrastructure that would facilitate the flow of data among systems. And this entails, just to walk quickly through like the components of, in this particular case, what would this infrastructure do? It would match identities between patients and clients. And I think we have some folks from the Indiana Health Information Exchange, which essentially provides that, I'll talk a little bit about it in a second, provides that function among electronic medical record systems. And we need the same kind of identity matching to be able to share patient information across healthcare and human services. Aligning vocabularies to speak to the earlier challenge, systems that can translate between different systems, between the vocabularies used in different systems. Exchanging updates, sharing personal information, like FHIR makes it possible, but infrastructure is needed to actually make it happen. And managing consent and permissions, which is a beast of a problem that I'll speak more about later. I think of all of these, the aligning vocabularies may be optional, but everything else is like, this is what we would need to be able to do for different organizations using different software systems to be able to interact with each other and share information about their patients. We have precedents for this. Health information exchange systems are infrastructure that enable different electronic medical record systems to interoperate. And it's a mixed bag as far as I understand. We could hear maybe some details from people on the call, but basically if you have different electronic medical record systems used by different hospitals, or even the same electronic medical record software used by different hospitals, health information exchange enables the routing of that information from one system to another. And they're designed in different ways. They have different business models, but we know it's possible. And now we have one example of a community information exchange. This was developed by 211 San Diego. A community information exchange is like a health information exchange, but for non-HIPAA covered entities, or at least to bridge healthcare entities and social service providers. It's essentially the same set of functions, only dealing with a much more diverse, heterogeneous set of kinds of care providers. So again, to loop back, this is the vision of community information exchange, where you might have multiple different kinds of organizations connecting people in need with services that are available to them, but they all interoperate with each other through some sort of common infrastructure that ensures that identities are able to be matched and information is able to be shared in a way that is also monitored and governed. So unsolved problems when it comes to the infrastructure piece, because we have precedents for it, but it's not something that people really understand. Infrastructure is an inherently abstract concept. And especially in the United States of America, it's something that people really struggle to think about. People immediately ask me, what does it look like, a community information exchange? And the thing about infrastructure is that if it's working well, you as a user don't see it. You might not know it exists, right? You're using a thing that's using infrastructure, but you don't necessarily interact with the infrastructure. And when you're trying to sell this idea that you can have different software systems serving different parts of a community and they can all interact with people, it's very difficult culturally for decision makers to understand that in ways that I actually think may be getting worse generation to generation, especially in this country. Economically, I mentioned 211 San Diego. They are in a wealthy county, in a wealthy state that has a well-resourced healthcare sector. And they got millions and millions of dollars, and it took them 8 years to build a community information exchange, and it's still not clear how they are going to sustain its operations. And this is a known phenomenon. Brett Frischman, among others in this community, writes about how infrastructure is often not provided by the market that will depend on it. right? It's not clear how to sustain infrastructure in large parts because it's difficult for anyone to capture the value of that infrastructure or even measure the value of the infrastructure because real value is being generated downstream, right? The infrastructure itself is the thing that enables the valuable things to happen, but nobody wants to pay for that thing. That's why usually the government steps in to establish infrastructure or some sort of other method of aligning an industry around some sort of pre-competitive set of functions that they all support. And we have yet to figure out how that's going to be sustained here. And finally, ethical. And I don't have this in quotes because nobody asked about this in my experience. People, when you bring up the question of harm from the prospect of sharing data across systems, the most immediate and almost ubiquitous response is, oh, well, these systems will be compliant with all regulations and they'll be secure from cyber attacks. And regulatory compliance and system security are woefully insufficient answers to the question of how are we going to protect against harm. We're talking about people's information, vulnerable people's information, being shared across not just technological contexts, but not technological boundaries, but institutional contexts in ways that could potentially have serious ramifications, potentially even greater risks than health information exchange, because you're talking about integrating the housing authority and the justice system with people's care providers. And the potential for even unanticipated harms is very significant. And the question of how infrastructure can ward against those harms, I think is a critical one that we haven't even started to really dig into. So here's where this can all come together. And this is the place for which we have almost no precedence. Governance is how we can address all of those unsolved challenges. And right now, governance really pretty much happens in all these systems between the organization that pays for the software and then the software provider and their associated lawyers. That's where governance happens, is in the data use agreements that one institution draws up with the software vendor. And that's not data governance. I have heard it described. I've been at prominent social determinants of health events, conferences, where people, are describing data governance on stage, and they're saying, well, data governance is kind of like, when you go to a restaurant and you order from a menu, you just select what you want and it comes to you. Like someone actually used that metaphor, and because they're trying to explain that like data governance is where choices are made, but they don't elaborate the metaphor of like data governance is also like, the process of inspecting the safety of the food and the decisions of how information about health, the health of different food is presented on the menus, and how all these decisions that keep people safe in that restaurant are made. There's very little thinking about how to design for those kinds of conversations outside of the context of regulatory compliance. And so what we need are systems of governance that can, first of all, cope with the problem of differential vocabularies of different kinds of people in different contexts using different words to describe the same things. Also, aligning incentives between social service providers who have way less power and way fewer resources than the health insurance companies that are driving this market. Managing consent and permissions of data that's being shared across different systems that have different rules and even different design purposes. And monitoring all these activities, not just individual exchanges of data, but also how aggregated data is being synthesized and used for algorithmic regulation, research, all kinds of other questions. And so that's what brought me to this question of the data trust, which I've seen people describing in various contexts. It sounds amazing. And also, I really don't actually know how to do it. So I'm excited to talk with this crew here. But for those who are joining outside of the Data Trust Salon series, the idea of a data trust, and maybe we can have people explain it a little bit more, is that there's an institutional design that is a legal instrument to steward the management of data on behalf of some class or set of classes of beneficiaries. And this is an answer to the question of, if this data isn't going to be just owned by the software provider and like owned by individuals, right? People owning their own data, which isn't really a coherent idea. The data trust is potentially a vehicle through which a community can make decisions over what kind of things can happen with its own data. But it remains unclear to me, first of all, tactically, the process of how you would build something that we don't actually have many precedents for, and that many of the key players don't necessarily even want to go through the work of building, right? Like a data trust would constrain the ability for health insurance companies, foundations, software providers to do some of the things that they want to be able to do with this data. So the question of how to get their support to develop this form of self-governance is I think a tactically very difficult one. And the question of how to sustain, on top of everything else that all these institutions are trying to accomplish, how to sustain the mechanism of governance, I think also is an unanswered question. And those are only the first ones that could come to mind as I'm starting to work through this stuff. I'm sure there's any number of other challenges. And so I think this is a very timely topic, and I'm excited to be talking about it with you all. So I can wrap up here. There's more details I can go into in various directions, and I'm eager to hear what you all are thinking about now that we've walked through this problem. Right on. Thank you. Angie is, I think, probably still dealing with the Indiana snow day. The last talk I gave at Indiana University was like the last thing that happened before the school shut down for the pandemic. Like literally I like left the building and they sent a car to take me to the airport because like everything was shutting down. And now today is like in the middle of a catastrophic snow day. So I have real good luck going on so far with this institution. But yeah, so feel free to, I'm gonna review some of the comments in the chat and feel free to jump in and start asking some questions.
I got a question. Thank you so much for the presentation, first of all. It's an incredible problem. Like, yeah, there's just so many interesting elements to this problem, and I'm very excited that you're working on it. Let's see, I had a bunch of questions, but one
I'll
of the
also say that your writing on data trust has been very helpful to me. So it's awesome to be in dialogue with you. So thank you.
I mean, I agree with you. I don't think the world has figured out how to do data trust yet. So like, let's all figure it out together. But my first question would be more towards just to understand from the perspective of, I'm just going to go ahead and call them users, but like someone who needs some service. So yeah, a future patient, let's say. How does interoperability play out for them? Like, how does it affect their choices? How does it affect what platform they get to use? Like, yeah, what does it mean to them?
So the question is bringing it back to like the people who are seeking help, and
exactly.
how does this matter to them? So there's a range of possible answers to that question. Starting with so right now there are not enough resources to meet people's needs. So let's just start there. Period. Right? Like the real challenge of the social determinants of health is that we live in a society that does not effectively invest in people's well-being. And but you at least have the freedom to like whatever actually exists, you can go and like, you know, if you're eligible for those services, you can go and show up and present yourself and interact with them. And this market, they don't necessarily say it, but what health insurance companies are driving at is a future where actually social care is linked to the healthcare system, and your healthcare provider will refer you to a social service, which, by the way, is how a lot of other countries do it, right? Like Spain, England, like they have centralized healthcare systems, and if you need other kinds of non-clinical care, you can learn about it at your doctor's office, right? So that idea is not necessarily unheard of, but in our privatized fragmented system, it potentially leads to a situation in which you can only go to the food pantry that's at the church on the corner of your block if your church is a member of your health insurance company's network, right? And instead of these systems of care currently imperfectly, and oftentimes woefully and effectively, but at least they're being managed by communities to some extent. And there's a threat that these systems of care are going to be reorganized according to what can measurably demonstrate impact to your health payer's bottom line, which is not necessarily the same thing as what is valuable to you, right? Like some kinds of care are going to be easy for a health insurance company to measure and to say, yes, we are going to compensate this kind of care, right? Because we can see how it impacts our bottom line, so we will invest in it. And other kinds of care aren't going to be easy to measure or aren't going to be valuable to the kinds of people that cost health insurance companies lots of money. And it might become increasingly difficult for those kinds of services to be provisioned. But that's just on one level. There's also the question of like, what are your options for finding this information, right? And right now, like, you can call your local hotline, you can call your other local hotline, you can look on the internet, but there aren't great options for that. But the question is, can communities have the agency to develop options that are going to work for them? Or are these interfaces by which you look for help going to be locked up into this proprietary company or not? And to be clear, I think like all of these vendors that I'm talking about, I know pretty much all of them, and I have relationships with them that span from like cordial to pretty warm. And I think that they can bring a lot of value to these fields, right? As companies that can create useful tools that can help people do things, but they can't solve everybody's problem. There's no way. Right? We've seen what happens when one technology company tries to build universal platforms, right? It's like it really doesn't end up serving the vast array of human needs to try to solve problems at scale, right? And so the question of what are the available interfaces to you through which you can interact with different kinds of care systems, different kinds of institutions is very much at stake here. And I think in the longest term, if we are able to build equitable information infrastructure where it's not just like, oh, people consent to share their data, but communities are able to steward this information that's being drawn from all these systems of interactions, right? Then it does potentially create vast new possibilities for communities to advocate for better resource allocation, right? And for individuals to advocate for their own best interests. But if these interfaces and that resulting data are simply sort of like enclosed by these different companies, then you'll only be able to do that to the extent that the company designs a feature for you to do it, in accordance with its whim or the whims of the whichever institution is paying it. So. Yeah,
no, right. I think that's spot on. I think there's lots of people who have questions. I have many more, but
yeah, go ahead. For some reason, I'm not seeing names anymore. I don't know why. But go ahead. I see someone's hand up. Maybe that's Chris.
Yeah, I'm curious on these because I am a big fan of data trust and data pools. I do wonder the issue you get into about segmenting those pools. Do we not end up with sort of a similar sort of problem as you get with your risk pools? I'm in trying to solve the problem. The way I guess I've sort of wondered if we could look at it is if we require essentially third-party cleaning of data, would that not in some ways get us to where we're looking and go? So if we say right now, if we look at data as the actual package of value, and right now we have full vertical integration of collection to processing to use layer. If we actually identified you can't, so when, I'm historically aggressively against Elizabeth Warren's 34 model of breakup of Facebook because the Oculus, Facebook, Instagram, those are all use layers and they're all equivalently the same. I'm just finding a different format. But if we actually horizontally fracture instead and say maybe you can collect, but you can't collect, process, and deploy data, do we get to the same result as what is sort of a massive data trust, but we don't actually have to come at it from saying what does the actual trust, what does the pool look like? We just say we don't know what it's going to look like. You're going to have to figure this out, but you're going to have to actually get the data out. It's going to have to get cleaned, and you're going to have to find market rate for the cleaning before you can use in your use layer.
Yeah, I mean, I think I'm not a technical guy, so a lot of questions, I can at best understand the external shape of them and hope to create space for people to start digging into some of the harder stuff. But the closest that I've come to answering this question of how would a data trust be sustainable, I think touches on some of the issues that you're bringing up, which is all of these are things in a world where communities accept that one software system is not going to solve everyone's problem, right? And you still have institutions that are like, okay, well, we want to do this kind of program to coordinate care for this kind of patient. This is a big strategic priority for us as a health insurance company or a managed care organization or a health network. And so we're going to develop a software program and a partnership model that will enable different care providers to share information across systems. A data trust could be in a position to provide intermediary data services, right? That could facilitate the cleaning, the alignment and curation of data across different terminologies, and provide the service of monitoring, and even provide institutional services of like an ethical audit. Those are all services that the data trust could potentially provide for fees, right? And how to design this, I don't know. It's a little bit of a chicken and egg, but like if every health system in a community is a part of this data trust and understands that like for them to do programming, software and institutional programming that connects people to services and monitors their activities, they have to pay for this intermediary to, first of all, help them do it, and also monitor how they're doing it. Right. So the first one is increasing their potential chances of success, because almost all these projects fail. And if you have an institution intermediary that's like, we can help bring best practices and provide training and support, you may actually help institutions save money, right? By having that intermediary that can facilitate the flow of data across pools, right? Which is otherwise very susceptible to failure or vendor capture. And if we can figure out how to establish the norm that all of this stuff should be governed, should be monitored and evaluated by some democratic process, then you can also institute fees that essentially have institutions that stand to benefit from these interactions pay to make sure that those interactions are monitored and done ethically. How to do that, I'm not really sure how to like get there, but that's as close as I've gotten to imagining what would actually be sustainable for this kind of governance system.
This is I think the model, unfortunately, that might be useful, even though it's broken, is credit rating system, right? Mm-hmm. And so I say that because there is, no recourse. I think I still have a set of golf clubs on my credit report that keep popping up. I don't golf, and it turns out they're bought by a dude who was born in 1934, and I wasn't. So, and I just for some reason can't get rid of them. And so while I think that the oversight of that is bad, the issue is when I look at this from, for example, a marketing standpoint, if you use certain tools to go and scrape data, even if I have, even if I'm the collector of the data, I'm the origin of the scrape, you could put in a layer which identifies, okay, this is a good piece of data, medium data, risky data, and you would then be required to only be using data that's actually gone through a risk assessment similar to a credit report. Yeah. And so I wonder if structuring the credit rating system is the most efficient way to go versus saying you just can't, you can no longer at the use layer use unevaluated data, which if you're going to use personal data, which then is going to force that economic model.
Right. I also see a couple of questions in the chat. Susan asked if this sounds like essentially what we need is an extension to ONC's TEFCA. And I think TEFCA is a policy framework that tries to align, a common set of agreements and data agreements for data exchange in the healthcare sector. And yes, I think one of the things that we need to figure out is how to extend that common agreement framework outside of the HIPAA contexts and into other contexts that could be also appropriate. Waldo, I see you raising your hand.
Yeah, so Chris, I'm glad you kind of brought that up, and Susan, I totally agree. The idea behind TEFCA is that there are these trusted frameworks, right? A network of trusted organizations that are agreeing to kind of do the same thing. When Greg was talking about HIEs and the CIE, for example, in San Diego, those are two, well, we kind of goof around and say that these are noun and verb type situations. The building, the organization is the noun, and the activity is the verb. And I think that what we're looking at from an HIE perspective, where we're trying to do more CIE, but we're an HIE, is we're looking at a lot of this social screening information and referral information, but then we're also looking at other social information from just utilization information that people have. So the difference being that you can go to a dozen different hospitals and places and people keep screening you for the same social need. And that the value of that is that, yes, you at a point in time maybe had a need, maybe it was unfulfilled, but just because you're screened for it 10 more times doesn't necessarily mean that you have 10 times the need. It's just that people keep screening you and you don't get satisfaction. This social utilization, you're actually utilizing something that demonstrates that you were eligible for something and that you were able to receive some kind of services. And if we can bring those two types of information into context together, they're really useful and they're valuable, and a value can be assessed. And parties who are participating in a trusted network where there's shared data governance, so social service agencies and community-based organizations that provide those services have an equal say with a huge hospital system on how that data is going to be used and how it's going to be retired when it's no longer necessary. That is, that's an idea that we're kind of looking at as a way, as a model for what Greg's describing as a data trust around this. It is, all very much smoke right now, but we are making inroads in some of these areas. But the releasing of that data in healthcare, we figured out how to exchange information across vendors. Vendors don't get to hold on or block information. We need to do the same thing in the social screening and referral area too, in order to make this really happen.
Yeah, and Waldo, your distinction between information exchange, community information exchange, health information exchange as a noun versus as a verb, I think is critical. I use it all the time, so thank you, because I first heard it from you. And I think it actually speaks back to Ostrom's reframing of the commons away from an understanding of like, the open field that's accessible to all, and doomed to failure, right? Because like if an open field is accessible to all, then everybody's going to bring all their cows to the field and they'll eat the whole field, right? And that's the classic tragedy of the commons, which ignores the possibility that a commons is not just the resource of the field, but also the system of rules and rule making that governs that resource, which can be set by the people whose interests are at stake, right? And so the verb of community information exchange is not just moving the data from one physical place to another, but it's deciding like who should decide what is possible and how do we know what's working and what do we do when things are not working. So we're at time, but I did see at least one other hand. If people have to go, that's all right. But Dr. Neal.
Sure. Real quick, to me, I've heard some. There's sort of a dilemma between compel and incent, and what I've heard is language that seems to be much closer to compel. How do we get people? How do we make people share their data and use it appropriately and all the rest of it? That feels like pushing a piece of string. Yeah. I feel like what I haven't heard is how do you incent healthcare organizations and social organizations to want to share data, to utilize shared pooled services in a way that delivers value to them. Yeah. Now, and when I put my healthcare provider hat on, I see the pain and effort to deal with HIPAA and CCPA and all the various regulatory frameworks. And well, the data is hugely valuable to me, but I would love if there was a way that some data trusts could make it easier to do the things I have to do to take care of the privacy and so on without impacting my ability to get my job done.
Yeah.
And so what I'd love to hear is thoughts about how do we incent, how do we provide, how does our data trust provide value added to the organizations that participate,
Yeah.
Or cost saved equivalently, in a way that makes it interesting and valuable to participate.
Yeah, it's a good question. I mean, I think that the incentives for healthcare providers are material, right? In that, like, you know, their ability to refer people out of the clinic to somewhere that's going to take care of their non-medical needs is a financial liability that they're trying to address. At least at the institutional level. The question of whether providers actually go along with that is another matter, because like health information exchanges exist, right? Health exchange data standards exist, but are different providers really exchanging health information? I hear very mixed reports. And when you're talking about then interacting with social services where there might not be any such incentives, right? They might even have disincentives. Right? They might not have enough capacity to deal with the clients that they're already caring for. And why are they going to start taking referrals from doctors, right? Or from care providers? And we see this happening in the market, right? Where all these vendors that we're talking about, they're like, we can enable closed loop referrals, right? Or a healthcare provider can screen someone, identify a provider that can meet their social needs and refer them. And when you go and you talk to the providers, they're like, oh yeah, now I get these automated emails from this random software website that wants me to log in. And I'm like, why am I going to do that? They're like, I got to line out the door. Why am I going to go to another website and get somebody else coming to me through some other company, right? It's the institutional incentives. It's not really clear that they're there. So as far as I'm concerned, the data trust right now is like, as this market's shaping up, how do we ensure that the capacity is there to govern that market so that we can, yeah.
There's sort of almost two challenges there, right? There's the incentive to share data, and then there's the incentive to refer patients. And right now the data is federated in a way that I might give you a glimpse at my data, but I'm going to own it and hold it. I'm never going to let you have it. Right. And that we got to break down. But that's different from the referral problem, which is if you're an orthopedic surgeon and I refer a patient to you, you're going to give me some co-marketing. You're going to pay me in some way that makes it worthwhile to make that referral. Yeah. But if I'm referring you to a food bank, then I feel like we've got to make it. We've got to tap into that incentive system where the hospital or the doctor or the health agency gets a credit or some value out of the referral, and also the recipient is incented or paid or covered to accept the patient that comes along with that. And those are two separable pieces that we have to solve.
Well, and I think the big question is who should be involved in solving them, right? Is it designers who get contracts from health insurance companies? Or should the providers, especially the ones who have more to lose, right, and have less capacity, should they somehow have their interests formally represented so that we're not just like doing a whiteboard and drawing some like simplified user journey with like simplified user persona, but we actually have the interests of the institutions and the communities at stake involved in making those decisions. And I think that's the big question that the market is currently not even coming close to asking. And the vision of a data trust at least creates the context in which we can start having those conversations. So
good, yeah, that's interesting.
All right, so I could keep talking about this all day. I think we are we're a little past time. Angie may still be dealing with the snow emergency. I can stick around for a while if people still have questions and they want to kick it for longer. Or we can wrap it up here. Would welcome feedback on this talk. I feel like I crammed a whole lot of things in, and it's a tough nut to crack. So, right on. Well, the Indiana folks, I'm eager to reconnect with y'all. I may have a couple of bits of news that you can use. And I'm eager to hear how things are going there at iHigh and with Indiana's 211 system. And if I can be helpful to you all, I know that Angie is really encouraging us to explore opportunities to work with the Ostrom workshop to potentially develop some governance strategies that might complement, whatever's currently happening in the state. So.
Oh.
Right on.
We'll be in touch.
Terrific.
Yes.
Oh, and I see there are some new chats. Anouk, it'd be great to keep talking. Cool. Thank you for your thought leadership in this field as well.
I feel like we're all just scratching at the very surface of the problem of data trust. But I would love to explore how to get both the providers, but also the patients themselves involved in any kind of governance design. Because this usually does get whiteboarded, and then someone comes up with some beautiful theory that really falls apart in practice. So
yeah. I mean, but the challenge of how to get patients involved is real hard. I mean, I deeply believe that is important, but how do you meaningfully represent all the people in a community in matters that are, so complex that, nobody, like, I spend my time thinking about this stuff, and I have a hard time really wrapping my head around some of the decisions that have to be made. And so it's not, saying that people should be involved in design and governance of the system is one thing, but what's the actual mechanism that's going to make that participation feasible at any kind of scale, even a small one, and meaningful? I think that's a real challenge. So.
Have you looked into any?
Has muddied the waters in terms of your rights on data in general, and that's not made it easier for consumers to make meaningful decisions about their data, I would say.
Yeah. And Anouk, you were about to say something?
Right. Yeah. So one of the things I'm exploring, because this is a question that comes up in so many different contexts, like. Either it's impossible to have a really representative group of people involved in the project, or just people just don't care enough, and they may care in some actual way, but not in a why do I have to be involved with some data thing? So first of all, to bridge that in terms of like communication and knowledge sharing and all the rest of it, but also to look at like what are their sort of natural advocates. And that can be completely outside of the health sphere. It can just be like, well, these are the demographics we're serving, who is generally advocating for them and getting them involved in some way. But yeah, love to think more about that.
Yeah, I think that's right. I mean, social service providers are a stakeholder, and to some extent are advocates of their clients. I think that is an imperfect proxy for a range of reasons, right? Their incentives are not totally aligned, but a governance system that did have specific representative social service providers who are formally a part of like governing the data trust, like that maybe gets closer, especially if there are methods then of like polling end users, right? Like, or like doing like sort of consultations through those social service providers with their own clients that could then generate like binding recommendations. Like I'm eager to start thinking through how do you practically solve that representation problem. And also I've been working in a community that also went through that point. And to your other comment, there are non-service providing institutions, advocacy institutions in any given community, and they might also be formally involved in the governance of the data trust in ways that could extend that representation at a somewhat greater scale than just individuals. So I'm interested in all that. If you have examples of this kind of thing being done in the wild, this is, if we can come up with like a clear vision of like, how do we want to actually do this? I think there are institutions out there who, like, maybe they're investing in a platform now. And when I ask them like about that narrow network problem, I'm like, so do you want like your community to only be able to access like social services or food pantries if they're a member of your, network? And they're like, oh, no, that's not what I want, right? Like when you actually reflect back some of the implications of these things to the institutions that are driving this market, they can understand, and some would actually invest, I think, in governance initiatives that are not necessarily in their like narrow economic near-term best interests, right? It is possible, but it's hard to do it when I can't even explain how it would work.
Agreed. Yeah.
Right?
Also, just as a as a side note, or rather footnote, when I said like getting advocates involved, I mean, initially I just mean in the designing of the governance phase.
Right.
And that's just, and I think there's still a whole question of like, who should then be in charge of a data trust, which as far as I can sort of guess, it will actually involve training people up to do that, because the intersection of like understanding the demographics as well as kind of the subject matter of health data is like, there are very few people who have the time and can already do this. Yeah.
If you know anyone, by the way, I would like to meet them. if you know anyone who understands like the problem space and also thinks about governance, you know, I'm eager to continue connecting.
John Wilbanks is really the only one who comes to mind, and I'm sure you already met him.
John Wilbanks has advised me over the years. Yeah, he's been a terrific advisor over the years, and I cite his definition of data governance often from Sage Biometrics. And I heard that John actually has moved on to something new.
Moved on, yeah.
It's a good reminder to go back and try to track him down.
Yeah.
Cool. Well, this is my information. If anybody wants to, please get in touch, and I'll wrap things up in a sec. And look forward to continuing the conversation. I believe this is going to be posted to the Ostrom workshop, and also my deck is something that I can share. I can make the deck available for people, and please do reach out and let's keep talking. Thanks, y'all.
Thank you so much.
I don't know if I can stop this myself.
Oh, I think if we all just leave, it will stop.
I can leave, but I. Okay, I'll text Angie and I'll leave. All right. Thanks for joining, everybody. Thanks for talking, Dr. Neal. Thanks, Dad. All right. Angie, I'm going to send you a message.